Your time now.
Okay, thank you, Dr. Bharti. Good morning, everyone. So I'm going to be talking about lamellar keratoplasty for keratoconus. These are my financial disclosures. So why should we do lamellar keratoplasty for keratoconus? Well, because penetrating keratoplasty has very good survival rates for keratoconus. As you can see in this graph, in this survival curve on this side, the bar line for keratoconus is the best compared to all the other indications. However, keratoconus is an ideal disease to do lamellar keratoplasty because the disease is primarily in the stroma. The endothelium is healthy. Most of the patients are quite young, so you want the grafts to survive longer. It's an extraocular procedure. There's less risk of rejection. There's less steroid usage, and the eye is technologically superior with lamellar keratoplasty compared to penetrating keratoplasty. If I show you two of my patients who basically had surgery, basically a 32-year-old patient, in one eye they had a lamellar keratoplasty, in the other eye they had a penetrating keratoplasty, and if you look at the endothelial cell counts after surgery and subsequently 2 years later, you'll see a massive reduction in the cell count in the PKI, but very good stability in the cell count in the lamellar eye itself. And of course, this person is only 32 years old. We want this person to survive until they're at least 85 years old. So which cases do we do lamellar keratoplasty for? So, of course, you can do in advanced keratoconic cases, that contact lenses that are intolerant, unable to do cross-linking, or some of the modalities you were seen earlier. It is possible to do in cases of previous high drops. I'll show you some examples. Moderate keratoconus if the patient is at high risk of developing high drops. These are males, young patients, high K readings at presentations. Down syndrome, of course, very important. If you can do a lamellar graft, you can take them off steroids. You don't know if these grafts are going to reject. And of course, atopes, again, they often have a lot of problems on the ocular surface. So if you can do a lamellar graft, it's better than doing a penetrating keratoplasty. Which kind of procedure you'll do this will be depending on the depth of the lesion that you're trying to get rid of. But essentially, you can divide them into three groups. Superficial lamellar keratoplasty for anterior lesions. For moderate codes, you can do ALTK, and for deeper lesions, you can do a DOLC, and this can be the pre-decimase lesion or a decimeters-bearing procedure itself. And I'll show you just some case examples of all these procedures itself. So we start with superficial lamellar keratoplasty. This is a case that was sent to me from Hong Kong, and what you can see is something that we call keratoconic pips. This is a keloid scar on the anterior surface. Often you'll see these patients who wear RGB contact lenses for a long time, and they'll develop this scar. If you look at the spectral domain OCT scan over here, you can see decimase membrane over here, so you can see the scar formation is generally above it. Sometimes it is associated with underlying scarring itself. So in the right eye, what we did was we did a simple, basically, superficial keratectomy on this side, and I basically managed to clean off the lesion itself here on the left. On the right side, where there was extra scarring underneath over here, the patient underwent DOLC surgery. So there's no need to perform more complex lamellar keratoplasty in a lesion if it's very superficial and above the levels of decimase of Bowman's membrane over here. You can simply do a superficial keratectomy. For more moderate cones, we can do basically ALTK. This is a patient with a very central cone. You can see on this side, uncorrected visual acuity of count fingers. You see a high sill on this topography map over here itself. Cornea quite thin, very, very central cone. These are the ideal patients. I know this is not the most common type of keratoconic we see, but this is an ideal patient for an ALTK procedure. How do we do the procedure? We do a two-step procedure. First, you basically do a cut over here with the LTK unit. This is the CB unit made by Moria. You first mark the cornea, and basically one cut rotating on the surface over here, we will basically make a flap in one smooth motion. There are different ring sizes over here in the kit. You need to measure that out with the K readings on the cone itself. Once you've made the cut over here on the central cornea, what you will do is you'll release this flap from the surface, and we simply put this back into place, and we leave this in situ for about 6 to 8 weeks. Normally it takes about 2 to 3 months for this to basically then stick into place. So you remove this from the blade, use the markings as you do basically when you're doing LASIK, just wash away the interface, put this into flap, and put a contact lens on the surface, and you basically allow this to heal. You don't need to suture this on the surface. You then go back to the same eye. About 6 to 8 weeks later, you basically know how deep you basically cut in the first procedure. We use a Hana-Trifine afterwards to go back into that level of the interface that we've cut with the first procedure. And what we do is we simply dissect right down to that same level. Now this Trifine is normally about 8 millimeters. This flap is normally about 10 millimeters, so you have a skirt all the way around. Once you've gone past the intersection, you can see over here, what you'll do is just use a Sinskey hook. You find the edge, and you can simply just reflect this back. Okay, and you get a nice smooth interface on the plane itself. The advantage of this is that the interface plane is nice and smooth because of course it's made by a microkeratome, so it's exactly the same quality as you get with a LASIK microkeratome. You need to be careful when you're peeling this back that you don't pull on the edge over here that's been cut with the microkeratome, and you simply peel this back and you can see that nice good quality interface. We know this is important for visual acuity in the long term. Then all you simply do is you cut your donor in the same thickness, you refine that with the same refine you've used to cut this with the Hana system, and then basically put this on and then suture this with any technique that you want. And normally we use a mixture of either single continuous or basically interrupted suture. There we go. So this donor's just been cut with the LTK system, and we just simply suture this. It's very important when you're suturing this that you suture the outer ring as well as the donor. So you must pass your suture through here, through the outer ring itself, because of course otherwise the flap will basically move, because this has basically been cut with this system. This is the same patient post-op, so this is the pre-op readings over here. This is post-op, 20/40 visual acuity, very good refractive error outcome, and you can see we can change the curvature. Ideally you want the corneal thickness to be above 550 microns afterwards, and if you want to do any surface treatment or any refractive surgery, you can then do that on top of this to fine-tune the result itself. For more deeper lesions, of course, you must do basically a dog procedure, and I'm going to talk about pre-decimase dog, and then of course decimase-bearing dog procedures as well. The problem with dog procedures are, of course, you have to think about this risk-benefit ratio. If we go for a pre-decimase lesion itself or a manual dog procedure, the visual acuity may not be good as if we go for a deeper position, but the risk of perforation is much smaller. If you go deeper, you have a better chance of getting a better high acuity visual acuity, but of course you have a risk of basically increasing risk of getting a perforation. So the first important thing is you need to pick the right battles for the right patient. For somebody like this, who's a cone over here, you can do a big bubble dog, right down to decimase, you'll get a very good visual acuity result. Someone over here with a previous hydrop scar, this is a 19-year-old boy from Pakistan that was sent to me. It's very difficult to do a big bubble dog. If I do a big bubble over here, I'll perforate and go straight into the anterior chamber. So here you can do a manual dog selection itself. So preoperative selection is very important. You will get cases like this. So this is a boy from Vietnam, 19 years old, hand movements, visual acuity, who has a hydrop basically over scar over here. Most of the time, most people would think about doing a penetrating keratoplasty for this procedure. It's possible to do a DOLC in over here, but this is a manual dissection procedure itself. But of course, with the scars in the central visual acuity, you have to explain to the patient there may be some residual deficit on his visual acuity. But the key thing is this is his own endothelium that he will maintain, as opposed to the endothelium from a penetrating keratoplasty. If you do a DOLC procedure, do you get a better result with decimase bearing or non-decimase bearing? This paper from Vincenzo Saracola in Italy will show you this is the pre-decimase lesions, this is the decimase lesions itself. Of course, if you look at the early visual acuities, the visual acuities are better in the decimase bearing procedure itself, but if you look in the long term, the pre-decimase visual acuities keep on improving itself. So even if you get a pre-decimase surgery, the visual acuity does get better, but you have to wait longer. There is evidence from the literature that if you leave less stroma, you basically do get better visual acuity results. So this supports the previous paper, and what you can see over here, with if they left less than 20 microns, the visual acuity was better than if they left greater than 20 microns. So if you get a very deep decimase bearing dissection, you do get better visual acuity results. An important thing to understand is that different ways to bear the decimase. You can use a peeling technique, you can use a conventional air technique, you can use a combination of viscoelastic and bubble technique, or you can use Shigata's visco-bubble technique itself. And each of these techniques will allow you to get to decimase bearing itself, and often I'll use a combination of air or visco-bubble air technique itself to get down to that decimase membrane itself. And once you can see the decimase membrane, then of course you know you're as deep as possible to safely basically put the donor cornea in itself. And it's important when you're learning this kind of surgery that you use a combination of techniques that you're happy with to achieve the goal of basically decimase bearing. It's important to also remember that your bubbles are going to be different. This is a young bubble on this side and an old bubble on the left-hand side over here. In a young bubble, it's very difficult in a 15-year-old to separate decimase membrane. The adhesions are very, very strong. So you will never get your bubble all the way out to about 8 millimeters or 7.5 millimeters over here. In an older person in mid-20s to 30s, it's very easy to get the bubble out to the 8 millimeter zone over here. So don't keep on trying to inject over here, otherwise you may rupture the decimase membrane. Is there evidence that basically decimase bearing is better than basically pre-decimase? If you look at the visual acuity results post-operatively in a paper that we published in the American Journal of Ophthalmology, you'll see that the higher percentage of 20/20 visual acuities are obtained in patients who basically get decimase bearing, then penetrating keratoplasty, and then manual DOLC itself. This was only looking at follow-up up to basically last 6 months itself. So you do get, if you can bear decimase membrane, more of your patients are going to basically see better. If you look at the long-term complications, of course, most of the complications with PKs either related to allograft rejection or basically steroid usage itself. The advantage of DOLC is you have a much slower risk of getting allograft rejection, and you do not be so reliant on basically using topical steroids. What happens with the pre-decimase cases? If you can't bear decimase, there's no need to worry, because the visual acuity that I showed earlier keeps on improving itself. If you do get stromal remodeling, they do see better. So in conclusion, the results of penetrating keratoplasty have not improved over the last 20 years, despite improvements in our microscopes, lasers, and the endothelial cell loss, even from the CDS, was 70% at 5 years itself. There are huge long-term benefits for doing DOLC surgery over penetrating keratoplasty. If you look at our Kaplan-Meier survival curve over here, this is a DOLC survival, this is penetrating keratoplasty. 84% survive basically by 10 years. Thank you for your attention.